This episode is for education and awareness only. I am not your doctor, I'm not your pharmacist, and I'm not your lawyer. This is not personal, medical, legal, or financial advice. Medicare rules can change, and how they hit you depends on your state, your income, your health, your plan, and your specific drugs. If something in this episode sounds like your situation, use it as a starting point and talk with a qualified professional who knows your local rules. You know, I keep hearing the same line from seniors. I thought they closed the donut hole, so why am I still paying so much for my prescriptions? For years, the donut hole was the scary middle of Medicare Part D. First, you paid a deductible. Then you had an initial coverage period where you and the plan shared costs. Then you hit the coverage gap, what is known as the donut hole, and your share jumped. Finally, if you spent enough money, you reached catastrophic coverage, and your share dropped again. That middle part, the coverage gap, was the donut hole. Now you hear good news. The donut hole is gone. Technically, it is. That middle phase of the Part D benefit has been removed. And starting in 2025, there was a hard cap on how much you pay out of pocket each year for the covered Part D drugs. On paper, that sounds simple and great. And of course, in real life, it's much more complicated. And the pharmacy middlemen, so-called PBMs, pharmaceutical benefit managers, are already adjusting to protect themselves, not you. This episode is about what really replaced the donut hole, how the new limit works, and what it means for your health and independence. This is the donut hole is gone, what that really means for your drug costs. I'm just going to go through a brief history of these four stages for Part D, trying to keep this short and plain. Under the old system, Medicare Part D had four steps. The deductible, wherein you paid 100% of your drug costs until you met the deductible, if you had one. Then you went to the initial coverage. You paid a copay or a percentage. The plan paid the rest. And then the coverage gap, where your share of the cost very significantly went up, and a lot of people truly got hammered here. And then catastrophic coverage, once your out-of-pocket spending got very, very high, your share went down. Again, over the years, laws reduced how much you paid in that donut hole. But the structure was still there, and people, rightly so, were still scared of falling into the hole. Now the gap is separate, as a separate step, is officially gone, so they say, or shall we say better, has it just mutated? That is a good question. So this is the current situation. So what changed in 2025 is 3 steps rather than 4 steps. So these are the deductible phase, where you pay 100% of the cost of your covered Part D drugs until you hit your plan's deductible. Medicare sets a maximum deductible. Your plan can choose a lower one, should that be their policy. Then you go into the initial coverage phase, After the deductible phase, you and the plan share costs. This is your usual copays or coinsurance. And finally, you go into the catastrophic coverage phase. Once your total out-of-pocket spending for covered Part D exceeds a number above about $2,100 for the year. After that, your share is zero. So yes, the old donut hole coverage gap phase is gone. Yes, there is now a cap on how much you pay out of pocket in a year for the covered Part D drugs. But that doesn't mean January and February suddenly got easy. It just means once you climb to the $2,100, you're done for that year. But you pay attention because more is coming. Just as an important aside, I must mention about the pharmaceutical benefit managers. And they're back, just like Jaws. And we just have to introduce them back into what we are trying to relay to you today. If you haven't heard about the PBMs, because they play a very important role in this, please view our podcast on pharmacy middlemen and how PBMs are bleeding seniors and threatening their independence. It's a sharp-hitting podcast and with a lot of information. That episode explains how the PBMs cut secret deals with drug makers, decide on which drugs are preferred, decide which pharmacies are preferred, and then play games with prior authorizations and step therapy. So to understand this totally, you should go ahead and listen to that podcast. So, is the donut hole really dead? Yes, on paper. But no in regards to it actually feels to you. So let's see what that means. On paper, that donut hole as a separate coverage gap step is gone. You move from deductible to shared costs to the gap, the cap that's been placed on for this year, which is $2,100. So in real life, there's still a paying zone. It just looks different. You still have to deal with your deductible. You still pay co-pays or coinsurance up to the $2,100. If your drugs are expensive, you may hit that number quickly and feel a huge squeeze early in the year. If your drugs are cheaper, you may never hit the cap, so the old donut hole fear just gets replaced by, why are these drugs still so expensive? There's also a new twist that many seniors may not have heard about, and that is the Medicare prescription payment plan. This lets you spread your costs out of your out-of-pocket costs across the year in monthly payments, instead of paying big chunks up front at the pharmacy. It is important to understand that this plan does not change the total amount. You still owe up to $2,100. It just turns giant early bills into smaller monthly costs, so you don't get smashed in January or February. So, the old donut hole is gone. The new stress points are how fast you climb to $2,100 and whether you can spread those costs out. Also, how your plan and its PBM play games with which drugs they're willing to cover and at one price. So this is a game, and unfortunately, we're in it. Now, with the new $2,100 cap, you are protected above that amount. Plans and the PBMs are on the hook for a bigger share of costs after you cross that line, along with the drug makers and Medicare itself. However, do you really think they will just quickly pay more out of kindness, the PBMs and the pharmaceutical companies? Of course not. So how do they protect themselves? They do it by tightening formularies, which will give you a smaller list of covered drugs. By using more prior authorization, we won't pay until we approve this, and they take their time. By using more step therapy, you must fail with the cheaper drugs first. By steering you into pharmacies and drugs that work best for their finances, not necessarily yours. So yes, the donut hole is gone, but PBMs are still sitting in the middle, trying to protect their profits inside this new system. Let's make this clear. This is not a debate regarding policy. It's very real world. It involves the health and independence issues. Obviously, if you can't afford to stay on the medications that keep you stable, it involves your heart, your lungs, your blood pressure, your mental health, your sugar, and so forth, you're going to be back in the emergency room lickety-split. You're going to lose strength, mobility, and confidence and independence. However, if there is an authorization step or step therapy, you're going to wait possibly for weeks for a decision. Sad, huh? You're forced onto drugs that don't work as well. Or you just give up. And it's so true. Because you're exhausted from the process. Your health is the one that takes the hit. If your local pharmacy is squeezed or pushed, you lose a professional who knows you and your meds. You lose someone who might catch dangerous interactions or dosing errors. For older adults, that's not a minor inconvenience. The point is simple. Your drug coverage rules are now one of the main things deciding whether you stay independent or get pushed into a crisis and dependence, and let me just say, yes, and death. Enough of the blah, blah, blah. Let's turn this into an action plan in plain language. Got to understand the new shape of the situation in one sentence. For 2026 and beyond, think, I pay my deductible, then I share costs until I paid about $2,100 out of pocket for covered Part D drugs. After that, I pay $0 for the covered Part D drugs for the rest of the year. That's it. No more separate donut hole step. If your drugs are expensive, ask about the prescription payment plan. If you know your medications are costly and you're likely to hit that cap, ask your plan about the Medicare prescription payment plan. The program lets you spread what you owe into monthly payments instead of taking a beating all at once, but you still take a beating. This doesn't lower the total dollars. It just smooths them out so you don't have to choose between your medications and eating or heating your house. And treat open enrollment when it comes like a very serious decision. It's a business decision. Every year during October 15th to December 7th, the enrollment, you have the enrollment window. Make a list of your actual drugs, names, doses, how often you take them. When you look at Medicare Advantage plans or Part D plans, do not just look at the premium. You have to check that whether or not all of your drugs are covered. What tiers are they on? Are any of them requiring prior authorization or step therapy? Are your pharmacies in network or preferred? Just don't stay in the same plan because it's familiar to you. Don't pick a plan because the overwhelming nonsense of these marginally honest TV ads look friendly. You're choosing who will be in charge of your drug rules and prices for the next year. Who is going to be in charge of your health directly, basically. If you need help, look at your local state health insurance assistance program. It's free, and they can help you compare based on your actual medications. This is complex, and it's something that one should really consider. Remember, if you're in Medicare Advantage, you get a second chance to do the selections. This part is important, and I can almost bet that no one has really brought this to you in a clear manner, or you may not even know about it. If you're enrolled in Medicare Advantage plan as of the 1st of January, you have additional 3 months to redo your selection. Okay? So let's take advantage of it. You only get one change during that period. Okay? But it can be a real lifesaver if you discover in January that your drugs are suddenly on worse tiers, your pharmacy is no longer preferred or in the network or even in business. Got to worry about that today. Your doctors have become out of network. Or your out-of-pocket drug costs are turning out much worse than you will ever led to believe. So the rule is use that October 15th to December period to make your best choice or guess. And then if you're in a Medicare Advantage plan and it turns into a disaster, use that second period as your do-over. Most people don't know this. No excuses now, because now you do. You have a very, very good for-free resource, and that is your pharmacist. Use him as a partner or her, not just as a cashier. Your pharmacist sees the PBM games all the time and the plan rules in action every single day. Probably one of the greatest experts in this area in general. Ask him, is there a cheaper drug that would work just as well for me? Be surprised. Is my plan blocking a better option because of their rules? Would using a different pharmacy or a slightly different drug lower my cost? A good pharmacist can often suggest options for your doctor to consider that save money and avoid some of the plan's traps. Remember, do not fight this alone if you are struggling. If you're getting denial letters, getting hit with surprise costs, or just overwhelmed by the phone calls and paperwork that you have been doing, let's bring in the bullpen. Bring in help. Could be a family member or a trusted friend who can sit with you, just sit with you, and manage calls and appeals. A good doctor's office staff that is willing to push back on inappropriate denials and the so-called step therapies. PBMs and plans count on you being too tired to fight. You don't have to fight alone, but you have to fight. Yes, the donut hole as a separate coverage gap phase is gone. Yes, there is a hard cap on out-of-pocket covered Part D drugs, which is a real improvement. But no, that doesn't mean the system is suddenly fair or simple. No, PBMs and insurers do not become charities. Remember that. And no, you cannot go on autopilot and assume your plan will take care of you. Here's the picture. Although the donut hole is dead, the fight over what happens under and around the cap is just beginning. Your job is not to memorize every rule. Your job is to understand the basic shape of this complex benefit. Use tools like the prescription payment plan if you need them. Take open enrollment very seriously based on your real medications and the real pharmacies that you have been using. Remember your second chance window, which is this January through March 31st, a time frame. If your Medicare Advantage plans turns out to be a trap, use pharmacists, friends, families as advocates and as allies to help you change. And if you want to understand the middlemen sitting in the center of all this, go and watch the podcast that we have put together on details regarding the PBMs and how they are bleeding seniors. Okay. Our tagline is information plus knowledge equals senior power. Use this power at the pharmacy counter. Use it when you pick up a plan. When you pick a plan, okay? Use it when someone tells you, famous expression, don't worry, the donut hole is gone. On paper it is. In real life, you still have to protect yourself. Thank you for listening to this podcast, and we look forward to give you continuing support. Take care.